Oh, I got it. So some of this will be obvious, some of this you guys know, but it's kind of, I just kind of wanted to go through everything as a whole so that everybody kind of gets up to the same speed and the same page and everything. Okay. So we're going to talk about a couple things with GDV. So we're talking about incidence and risk factors, some pathophysiology, some information about surgery, perioperative complications, and post-op management. So kind of as we know, there's some breed predisposition. So generally large giant breed, deep chested dogs. Some breeds have a higher incidence like Newfoundlands. Great Danes obviously have a super high risk, things that we've kind of all seen before. But really anything theoretically deep chested. I've seen, actually my very first GDV back when I was a rotating intern was a Dachshund. Random. And then, we've seen everything else in between. So some other risk factors, older dogs increases morbidity and also increases mortality. If they have a first degree relative with a GDV, so any purebred dogs that have GDV, I always ask if they know of any family members. If some of these others are kind of loosely associated, but some people think that some studies have shown that a faster speed of eating, so dogs that just wolf down their food may be predisposed. Some people think raised food bowls will increase the risk of it. Other people say it decreases the risk of it. Sometimes people think that eating dry kibble predisposes them to it. I think that's kind of variable again. High anxiety levels, I definitely think that is predisposing animals to it. Like a lot of GDVs have a history of recently being boarded or having a trip or something stressful happening in their lives. Interestingly, there is a bit of seasonality to GDV too. We do notice and there's been a few studies that show this, especially in military dogs that are relatively a controlled population, where there's an increased risk of GDV with changes in barometric pressure. So in the spring and the fall, when the weather's changing, there's large weather shifts, there's actually a higher incidence of GDV. Not really sure how that's related, but it seems to be. So for pathophysiology, first, let's talk about what happens during GDV, or what causes it. We don't really know. There's a lot of studies out of England that say the dogs that run the fence line have a higher risk of GDV. There's basically a lot of stuff, anything you want to support, you can probably find a study to show that it causes it. And then next, we're going to talk about what happens during GDV. So pathophysiology, there's kind of three components here. So first, there's the GU, the gastric outflow obstruction. This can be a foreign body. It can be something that we don't know. Basically, an unknown cause causes an outflow obstruction. So the stomach starts to dilate with gas and air. Normal emptying is then inhibited, and you get continued distension of the gas or continued distension of the stomach with air and fluid. And then eventually you enter into a true GDV state where it actually rotates, sometimes with the spleen. You get venous congestion and mucosal damage and everything else associated with that. So now let's talk about where the stomach goes. So the pylorus normally sits on I always have to look at it, right? The right side of the body. And so I hate when, I was one of those people in vet school that hated it when everybody described it as clockwise or counterclockwise or whatever. You need to describe it in anatomic terms. So the pylorus moves ventrally and to the left. So it rotates that way. It can be really anywhere between 90 and 360 degrees. Usually it's around 240 to 270 degrees rotation. So usually the pylorus is kind of flipped over and on the left side there, sometimes dorsally. We can occasionally see some that are sort of more like an intermittent GDV, where sometimes it's like 90 to 180 and seems to move around a little bit. Those dogs are usually more stable. And I've seen it twisted further than 360 before too. So really anywhere in there is possible. So now let's talk about sort of three big areas within the body here. Let me just see if I can slide this over. So GDV causes three main categories within the body. So there's decreased ventilation, decreased venous return, and then eventually you get compromised gastric function. So looking at the decreased ventilation first, you get a decreased tidal volume, a VQ mismatch, which results in a decreased partial pressure of oxygen, and then consequently tissue hypoxia. And so basically you're not matching your ventilation with your perfusion appropriately from decreased partial pressures of oxygen. Decreased venous return now can cause decreased perfusion because you're not getting blood back. So in some experimental studies, there's when you induce GDV, when you cause it, basically they look at in different blood pressures, particularly the mean arterial pressures in a few studies, and they show that it takes only about 30 minutes to really decrease the venous return and decrease the perfusion really significantly and rapidly drop the blood pressure. And that's definitely something we can see clinically. So you think about it, you're collecting blood in the spleen and the stomach. So all of that, anything coming from the back half of the animal basically can't make it all the way to the heart. So when you have decreased perfusion, of course, you get organ damage in the stomach, especially. This means gastric hypoxia. For the kidneys, which are also rapidly affected, as you know, kidneys get lots of the blood, so they can have an acute kidney injury pretty quickly. For the heart, it means myocardial ischemia, so decreased perfusion to the coronary vessels. One thing I think people don't realize is that the heart gets its own blood, so it perfuses itself through the coronary vessels only during diastole. Those valves actually close during systole. So one thing that's actually important periodically to remember is that diastolic blood pressures matter, especially when it comes to heart perfusion. And then when you have myocardial ischemia, you can get arrhythmias and then consequently have heart dysfunction too. So now when you're looking at compromised gastric function, you pretty quickly can get gastric hypoxia, results in gastric necrosis. Sometimes you can get a perforated stomach, unfortunately, too. You also get more endotoxins absorbed from the GI tract, especially the stomach, which you can then get a patient that presents into septic or endotoxic shock. And peritonitis is almost always a result of GDV, but sometimes worse than others. Secondarily, you get significant ileus, which further accumulates more fluid in the intestines and GI tract, and then you can get some pretty significant electrolyte changes rather rapidly. So shock, just to go back a little bit, let's talk about the different types of shock. Oops. Here we go. So first there's hypovolemic shock. Hold on, there we go. Which is like hemorrhagic shock, blood loss, non-hemorrhagic. So things like burns and stuff that take a lot of fluid away from the patient, and also GDV. The other next type of shock is cardiogenic. So heart failure, basically. And then you can also have distributive shock. So sepsis, anaphylaxis, and also like neurogenic shock too. Hypoxic shock is hypoxemia with things like anemia, carbon monoxide poisoning. Sometimes this can be metabolic. And generally, GDV patients, like we mentioned, are in hypovolemic shock. So in GDV, what's causing the hypovolemia? There's generally not a large amount of blood loss. Sometimes you can tear the short gastric arteries between the stomach and the spleen, especially if the spleen goes for a ride with the GDV, then sometimes they can have a little bit of a hemoabdomen. But most of it's from a reduced venous return. So there's like compartmentalization of the blood. Mainly the blood cranial to the diaphragm gets through, but it doesn't make its way back to the heart. So it results in a hypovolemia. And again, sometimes there's a hemoabdomen. So triage, let's talk about that. So patient presents, it's the right size. It's kind of just, sometimes they present kind of ADR. The owners just think that they're off. Sometimes they present with more obvious signs, but basically the first thing you need to do is confirm the diagnosis if you think it's a GDV. So these are some pretty classic x-rays. They've got the double bubble. You really only need one x-ray to confirm that it is a GDV, a right lateral. Next steps you want to do is you want to start getting the patient stabilized, because these are critical patients that can decompensate quickly, even if they look stable. And these are some of the most critical patients to get into the OR and get them rotated. About the only thing that I think is more critical is a mesenteric volvulus, which is essentially the same thing, just of a different organ system. But these are really, really critical. These are some of your most critical patients. And even if they look stable, they're not always. So I have a whole checklist I developed during my residency for our interns and a little bit of ER doctors, but mostly for the interns to help them, that kind of goes through things. So I'm happy to share that with anybody who wants it, but it's literally a breakdown, do this, next step, all the way down, getting into the OR. But generally, you want to place 2 IV catheters. Obviously, you want them in the cephalic veins for obvious reasons. If you put them in the saphenous veins, then you're not really pushing blood back to the heart, right? Because things aren't making it through. Then you want to give them a bolus of crystalloids, depending on how compromised they are, sometimes colloids as well. The next step is you want to decompress the stomach. So there's some arguments on both sides, whether you pass an orogastric tube or do a trocar. I prefer the trocar, and I think generally it's easier for people. It's faster, and you don't need to be sedating the patients for it. So I like to use whatever large gauge IV catheter you have around. A 14 or a 16 is ideal, but basically whatever you have is fine. Honestly, back when I was, before I was just getting into vet school, I think I was a first year still, and I was working at Banfield as a tech essentially. And I watched one of the doctors at Banfield trocarize a giant St. Bernard that had been boarding, that had GDV, with a 22 gauge catheter. For whatever reason, that's all we had available. So just use what you can, but the bigger the better. For passing an orogastric tube, you really have to, most of the time you have to sedate the patients. You need to be firm but gentle. It can be really difficult to get it through the esophageal sphincter, especially when everything's twisted. And I think there's a higher chance that you're not going to actually get into the stomach. If you do get into the stomach, it's definitely a better decompression. You get more air and everything else out, sometimes fluid and things like that. Whereas with the trocar, you really just get air out. Sometimes you have to reposition, that kind of thing. So just either way, do whatever you're comfortable with, but get it decompressed as quickly as you can after presentation. So this kind of highlights some of the things we just talked about, trocaring versus orogastric tube. Some people report a potential splenic laceration with trocarization. Clinically, there's been a few studies that looked at it and they haven't seen anything significant. If you get a little squirt of blood out the catheter when you're trocarizing, just try for a different position. And I haven't seen any studies that have shown significant morbidity associated with accidentally poking the spleen. Usually clinically, even if I've seen a patient that's been trocarized and had the spleen poked, it's not a big deal. With the orogastric tube, again, sort of gentle but firm. So getting in there, you have to push a little bit to get it through the esophageal sphincter, but then you have to be careful because theoretically, if the stomach is necrosed, you could easily pop through the stomach with your tube and perforate the stomach. So that's not ideal either. So that's another reason why I think generally trocarization is a little bit easier for everybody to do. It's a little bit faster. You can do it while the techs are, say, placing catheters or anything like that. So some additional diagnostics to run. Generally, you want your baseline. So CBC chemistry panel, definitely include electrolytes in it. We especially want to look at potassium. Ideally get a lactate level as well and get some blood pressure. So it's, interesting to measure the blood pressure in the front leg versus the back leg, but ideally you want at least a front leg because that gives you a good idea of what's getting to the heart or not. Some people run clotting times. I'm kind of ambivalent about it. Most coags are slightly prolonged when they come in with GDV. Similarly, they have mildly decreased platelets. And honestly, that's not a reason to not go to surgery. Mild changes like that are associated with the disease. And I've had ER vets at other clinics back when I was a resident call me in the middle of the night asking what they should do, if they should send it. And the answer is yes, always send it. It's always surgical as long as the owners are a go. Like rarely if the patient's gotten into rodenticide or something weeks ago, that might change it a little bit, but still ultimately it's do surgery or the patient dies. So lactate, let's talk a little bit about that. Where is it and where does it come from? So let's start with how cells get energy under normal circumstances, which means let's talk about glycolysis. It's amazing. So basically glucose is converted into pyruvate molecules through glycolysis. So this is the basis of making energy as a cell. So in the process, you make 2 ATP out, 2 ATP are used and you get 4 ATP out along with 1 NADH molecule, which is, of course, as we all know, nicotinamide adenine dinucleotide, because you're all obviously biochemistry nerds like me. So overall, this is a neutral process. So it makes just a little bit of energy for what you put in, but not a whole lot. So this is the first step. The next step is the Krebs cycle or the citric acid cycle, which is also amazing. And basically you can put pyruvate into the Krebs cycle, make a whole bunch more NADH and sometimes FADH, which is the flavine adenine dinucleotide. But again, you only get 2 ATP out, and ATP is really the energy workhorse of cells. So there's not really a net gain in energy, but you're making a bunch of potential energy through the NADH. So then you go from the Krebs cycle into the electron transport chain in the mitochondria of the cell, which, as we know, is the powerhouse of the cell and is amazing, the best organelle of all. So the NADH and FADH travel to the mitochondrial membranes. It travels through the electron transport chain and is converted into a whole ton of ATP. So this is the bulk of your normal, oxygen-dependent cellular respiration. So this is what normally happens. But you have to use oxygen for this. So if you don't have oxygen available, if you're in a hypoxemic state, pyruvate can't enter into the Krebs cycle and the electron transport chain. So then in order to get ATP out, the cells have to do something else, which is the anaerobic metabolism, which is where lactate comes into play. So instead, it shifts how you make ATP. So it uses pyruvate at the end of the glycolysis cycle into lactate, which then lactate can be, pyruvate can be converted into lactate, which makes some more NADH, releases some hydrogen, and also makes more ATP. So this is called the Cori cycle, and it takes place mostly in the liver. Basically, glucose in the cells make pyruvate, which then through anaerobic metabolism make lactate, travels in the blood, goes to the liver. Lactate is converted to glucose. Also very cool, but very inefficient. So as a side note, this is similar to fermentation. So and other things like yeast, you could take glucose, you make it into pyruvate, and you make it into ethanol and make delicious beverages from that way. So lactate. Lactate increases in hypoxic states. You ultimately get gastric necrosis. You can have effects on your glomerular filtration rate. You can get renal damage. You can have splenic injuries. You can have myocardial injuries. Plasma lactate concentration is also associated with prognosis in GDV. So as much as you all like to learn about biochemistry, I'm sure it's also just really important to prognosis for GDV. So there's been a few studies out this. These are a little bit old now, but when you had a 9 cutoff for lactate, only about 54% of cases survived. So that's not really very good. With a 7.2 cutoff, it was 82% accurate for gastric necrosis with a sensitivity of 50%, specificity of 89, and 88% accurate for predicting outcome, which is survival. So one way to discuss this is what would potentially be a better way to describe this, because it's not very user-friendly, especially for owners. So serial lactates actually are much better. So in particular, final post-op lactates have been better associated with prognosis than one single pre-op level. Basically, with these studies, we've seen a decreased survival when the final lactate is still greater than 6.4, indicating a high level of hypoxia. If the absolute change in lactate is less than 4, or the percentage change in lactate is less than 15%. Conversely, we saw increased survival if the final lactate is less than 6.4, absolute change in lactate is greater than 4, or the percentage of change in lactate is greater than 42%. So I think it's most useful to run lactates when they come in. It's useful to get a gauge. If the lactate's super high, it could be a poor prognosis. So if you have owners who are on the fence about if they want to do surgery or not, maybe that would help shift them one way or another if the lactate's low or high. But it's also not a reason to necessarily stop. Even if the lactate's high initially, I wouldn't say that it's a guarded or grave prognosis, as long as the owners are on board with surgery. But it is something we use very good way to decide how treatment's going. How well are we rehydrating them after surgery? How well are they responding to treatment? Are we correcting their electrolytes? Are we correcting the hypoxic state? So there's some other measurable parameters. There's base excess and cardiac troponin that we can measure. So base excess is the amount of negative ions in the bloodstream. So outside of the ones we typically measure, like chloride mainly. Base excess, or the amount of negative ions in the bloodstream, should decrease as lactate increases. So it makes sense that as positive ions increase, like lactate, base excess should decrease. So it has been shown to associate with lactate, but it's not really a great prognostic indicator. I haven't seen any studies that really give us a good correlation with survival or prognosis. So overall, lactate seems a little bit better, but base excess, at least theoretically, should follow along with that. So cardiac troponin, where does this come from? Cardiac troponin, INT, they're a measure of myocardial damage. They increase with more severe ECG abnormalities post-op and generally are associated with a worse prognosis. So they have been shown to increase with GDV, but it's kind of, again, it's difficult to measure, especially when you're not in an academic setting where you have access to a big reference lab right there. And honestly, really, you can look at an ECG to know if there's abnormalities. Fortunately, we have ECG and telemetry readily available here, so it's not difficult to know if they're having an arrhythmia. You just put an ECG on. So I don't really think it's super useful, but it has been reported. So surgery. Surgery is the treatment of choice for GDV. So after you trocarize it, you want to get into the OR, you do a ventral midline laparotomy, you derotate the stomach, decompress the stomach. So typically I have an assistant, my anesthetist usually passes orogastric tube after I derotate. You want to feel the stomach really well, make sure there's no foreign bodies in there. Theoretically, there can be, and I have seen 1 or 2 patients that have had them. Sometimes if there's lots of like chunky food or just sort of mucousy goo in the stomach, you can do gastric lavage as needed to help decompress it. But basically you should feel a nice, basically like a big burp out of the orogastric tube and see a nice decompression of the stomach pretty rapidly as soon as you get the tube in place. For any horse people here, if you've ever heard the term chase the bubble, that's what you want to do. So you kind of move the tube in and out, chasing the bubble, getting fluid out through the tube. And then sometimes after you decompress the stomach and evaluate it, sometimes you have to do gastric resection, which is a little bit more advanced, and it just depends on what it looks like. There's a variety of techniques for that. Some people just fold in the stomach and suture over it, and some people actually resect. It just depends on the surgeon and how it looks at the time. And then the other side of things is you want to explore the rest of the abdomen. So first priority when you get in there is to derotate the stomach. Honestly, you can't really see anything else when the stomach's big and in your way. But after that, you want to do a full abdominal explore, feel the pulses of the spleen. Spleen's often looks a little bit hemorrhagic, at least where the blood vessels are inserting on the mesentery there. But as long as the pulses are good, I leave it in. If the pulses feel questionable at all, or or obviously some of the vessels have been torn, then we'll take it out as needed. One other thing just to mention, when you're looking at gastric necrosis, a good way to to assess the different layers of the stomach is through something called the seromuscular slip. So you actually like pinch the whole stomach and then pull up and let it kind of slide through your fingers, and you can feel the different layers of the stomach that way. So gastric perfusion works a little bit different than other things. So the perfusion goes to the outside, the serosa first, and then to the inside. So if the outside looks awful, the inside is even worse, and vice versa. So if the outside looks okay, but you're kind of questioning if the stomach's okay or not, if it needs to be resected, if you can do that seromuscular pinch and feel nice, clear layers, then it's probably okay. But if it gets real mushy and you can't feel the different layers very well, then it's probably too necrotic. And worst case, obviously talk with the surgeon who's on call. So gastric foreign bodies, they can predispose them to GDV. In one study, there was as much as a 5-fold increase. Food and other material can also cause continued inflation of the stomach. I had one dog that actually got into bread dough, into yeast, and that was partially why it bloated, is because the yeast was fermenting in its stomach. So you want to really palpate thoroughly, and then lavage if you need to, if you're not sure at all. And if you're at all unsure, you can do a gastrotomy. And you can always empty the stomach out that way, of course, with suction and everything else. And that's the definite way to be sure. Just be really careful about where you go. You don't want to go do your gastrotomy in the area of the stomach that's obviously really bruised or damaged. You want to try and go in the healthiest part you can. And if you're not sure, then it's a judgment call, or always call the surgeon who's on call too. So gastropexy always needs to be performed in these patients. 54% or higher have a recurrence without a gastropexy, whereas with a pexy, it's less than 5% chance of recurrence. And most of those have usually been found to actually have too small of a pexy. So what do you suture and where or to what? You suture the pyloric antrum. So the pylorus itself is quite small. That's the actual exit to the stomach. So you don't want to really suture that ever unless you need to. It's not where you want to do gastrotomies or anything like that, for example. You want to go in the pyloric antrum, which is right next to the pylorus, where it kind of widens a little bit again. So, and then you want to tack that to the right body wall. That's where it should normally sit. Here we go. So this is an example of an incisional gastropexy. This is just from Fossum. So you make a little incision in the body wall, little incision through the superficial layer of the stomach, the serosa there. I like to make my incision in the stomach first, and then kind of push the stomach against where I think it would sit. I think of it as the most ergonomic position, or wherever seems to be the most comfortable for the patient. And then I just use that little blood spot as my guide as to where to make my incision in the body wall. When you're making your incision in the body wall, make sure you know where the diaphragm is. The easiest way to tell where the diaphragm is to look underneath, and you'll see this little rim of fat right at where the diaphragm inserts onto the body wall there. It's really, once you see it and recognize it, it's pretty obvious from there on out. So go caudal to that. If you cut into the diaphragm, obviously you can cause a pneumothorax, and you don't want to do that. So then when you're suturing, it's really a simple continuous suture line, one on each side. Use a relatively large suture. If it's like a medium large dog, I usually use like 2-aught PDS. If it's a big dog, 0.0 PDS. I do think we have some number 1 PDS if you're really worried, but that would have to be like a super, super giant Mastiff. I usually wouldn't use that. And then I like to suture the cranial side first. I'm a lefty, but I've found that other people, when I've been training interns and residents, even right-handed people think that too. So suture the cranial side first, go kind of from whichever side you want, left or right, across, and then do a second line caudal to it. And that seems to be the easiest for everybody.
Dr. Retallack?
Yeah.
So your picture shows a horizontal incision on the body wall.
Yeah, that's not right. That's
I know.
awesome.
Okay.
Yeah.
Just wanted to check that.
Yeah. So you want to go ideally left to right. You don't want to go cranial to caudal, because your gastropexy side will be short. That's awesome. And it's actually copied into the bias too. So there's a bunch of other types of gastropexies as well. There's belt loop, there's circumcostal. Theoretically, there's tube gastropexy, where you have placed a gastrostomy tube and actually pexy it essentially to the body, and then gastrocolopexy. Basically, in this situation, you wouldn't be doing any of them. Belt loop and circumcostal are where you take intricate muscle flaps and tie them around muscle or around the actual rib, and they're not any particular stronger than the incisional kind, and there's a lot more morbidity. They're a lot more technically challenging. Just don't do them. And then the gastrocolopexy, basically we never do. It's not useful. It doesn't actually prevent GDV or colonic torsions or anything like that. So I don't recommend them. And in this situation, you're not placing a gastrostomy tube, so that's not particularly useful either. So prophylactic methods, we definitely do prophylactic gastropexies. There's a traditional sort of open prophylactic gastropexy, of course, when you're in there doing something else, say like a spay or foreign body surgery or something like that, or splenectomy. There's laparoscopic assisted, which is what this picture is showing, where you put a little camera in around where the belly button is, find the stomach, pull it up to the side, and then actually make a full thickness incision through the body wall on the side to attack the stomach. And then there's true laparoscopic, where you're doing actual intracorporeal or inside the body suturing. Any of the surgeons here definitely obviously do regular prophylactic gastropexies. Some of us do laparoscopic assisted, and then I'm probably the only one that does true intracorporeal laparoscopic gastropexies at the moment, although I think Beulah wants to do some more of those too. So we have if you just in passing, if you have clients who want it, that is something that we certainly offer here. For laparoscopic, we usually ideally wait until the patients are about a year of age, so roughly fully grown. And we can do things like neuters or spays at the same time, usually just do an ovariectomy essentially through the same incision laparoscopically. Obviously, there's pros and cons with that if they're about a year of age. It's been reported to do it endoscopic assistant, where somebody goes in endoscopically, finds the stomach, and then you kind of localize them and then make a little incision. So it's essentially endoscopic assistant, kind of like the laparoscopic assistant, but just with an endoscope instead of a laparoscope too. So interesting, but not something we do commonly. So the benefits of prophylactic gastropexies, obviously it prevents GDV. I tell clients that their stomach can still dilate, it just can't rotate. So it really prevents the life-threatening part of GDV, but it can still dilate. And so I have had a few patients that I've treated, I'm sure plenty of other people have too, that have had a pexy but have still dilated. Usually you treat them symptomatically for basically gastritis. Some people give GAS-X and things like that to these patients. Some potential complications of prophylactic gastropexies are really just ileus, gastric motility issues. Zola actually did a study about gastric motility after a prophylactic gastropexy, where she had the patient swallow little monitors for motility, and they didn't find a change in the group that had pexies versus not. But I do think that if you're not careful about where you put your gastropexy, they can have discomfort from that. Sometimes I've had patients that go from being like a voracious Labrador eater to a little slower, a little pickier, things like that. And I think a lot of it's just due to positioning or the size of your pexy. So splenectomies, it's really a judgment call if you need to take them out at the same time. Sometimes it's controversial too. Some studies are more opinionated than others. Hypothetically, if you remove the spleen, so if you're doing a splenectomy for a different reason, like a splenic mass or something like that, you could cause increased motility of the stomach is the idea, and consequently lead to a GDV. There's arguments and studies on both sides. Basically, we don't really know. So it depends. If I have a dog that I think is really at risk of GDV anyway, it's something we offer to clients when we're doing a splenectomy, but sometimes I feel like a salesman doing that, and I don't particularly like that. So it just depends on the patient really and what the owners want. This was a study from 2012 that compared splenectomies versus enterotomies with the incidence of GDV, and they found no increased incidence. But this was a small study with not a lot of controls. The splenectomy dogs were significantly heavier than other non-splenectomized patients. And then also, if you have a dog that has hemangiosarc and it comes in for GDV 2 months after it had its spleen out, those owners probably aren't going to go to surgery because it's hemangio. So I think there's a bias there. Similar with this study, it matched GDV with 2 other control dogs, where 4% of patients with GDV had a previous splenectomy versus 1% of control dogs. But this was also comparing those without GDV to those with it. Some of the dogs had neoplasia again. So we usually recommend it if owners ask. I don't go too far out of my way recommending it unless they're really high risk. So some other risk factors. So generally there's about a 16% mortality has been reported for GDV. For really old patients, it's a little bit higher. If there's necrosis of the stomach, it's much higher, unfortunately, about 40%. Postoperative complications are present in about 75% of patients. So it's mostly just things we know that we treat for with GDV. So cardiac arrhythmias can be as high as 75%. It depends on the studies you read and how quickly you treat them. But DIC is certainly an option. Peritonitis, they called it only 4.8%, but honestly, there's some degree of peritonitis in every case of GDV because of just the nature of it. Some patients had hypotension. It's unclear, depends on the study, whether they reported it pre, during, or post-operatively. And then sepsis can certainly happen if the stomach ruptures. So overall, there's a worse prognosis if they have hypotension at any point, even pre-op. There's definitely a much worse prognosis if they've had clinical signs for greater than 6 hours. So again, these patients are super, super important, super critical, and they should be your focus while they're here, and basically focus on getting them into the OR as quickly as possible. Even if they look stable, they can decompensate extremely rapidly. Sometimes they've had signs for a few hours before they even present to you, whether they've gone to their regular vet and had diagnostics and then referred here for surgery, or whether they've just been home alone overnight and the owners don't know how long they were affected like this, or they at work or something like that. So it's super, super important to get them in decompressed as quickly as possible. Obviously a worse prognosis if they're in DIC or have sepsis. Peritonitis overall, especially like a wicked peritonitis throughout most of the intestines, is definitely a decreased prognosis. If they have to get blood or plasma during hospitalization, obviously that's a bad thing. You don't want to bleed so much, you need that. If they're older, generally there's a worse prognosis. And then of course, if they have gastric necrosis too. So post-op management, you know, really pain. I don't know. I obviously haven't had bloat myself, but I imagine that it's like the most nauseous feeling in the world, needing to throw up all the time and not being able to throw up. So I think of them as super nauseous. They're definitely uncomfortable. So pain meds at presentation is ideal if you can. It also helps just take the edge off, makes them a little more mellow. As you can imagine, they're can be pretty stressed out. You need to correct for any metabolic or acid-based and electrolyte disturbances. Sometimes they're hypokalemic, especially, so supplementing potassium after surgery. If they have any ventricular arrhythmias, those need to be monitored at least. Depending on the rate, you often don't need to give them treatment. Really, the treatment for arrhythmias is when they have BPCs or VTAC with a heart rate greater than 180, or if you're having R on T, where the two beats are really rapidly in close succession. The treatment for that's usually lidocaine boluses plus or minus a lidocaine CRI, and then if needed, starting them on sotalol as well. And most of the time when I've had a patient that's had arrhythmias after a GDV, at the 2-week recheck, I have them come back and we check an ECG at that time, and almost all of them are resolved unless they have some underlying heart issue already. DIC, obviously you need to treat that. Same thing with sepsis or peritonitis. So I like to give them a bunch of GI meds. So metoclopramide CRI is always a good idea post-op. Anti-nausea meds like Serenia or Dancitron. I think of them as having significant mucosal damage, even if there's no gastric necrosis. So we tend to put them on omeprazole or famotidine. I think I prefer pantoprazole and omeprazole. I also put them on sucralfate usually too, just in case. And then really, just like anything else, GI foreign bodies, start offering them small amounts of food and water and see how they handle it. Some of them bounce back really fast. So monitoring them post-op, obviously, I like to recheck electrolytes frequently. You can check albumin, things like that. Whatever seems to be most abnormal, just recheck it and monitor their response to therapy. So especially if they're having arrhythmias, monitoring potassium is really important. A lot of the antiarrhythmics like lidocaine and sotalol don't work very well if they're hypokalemic, or the cardiologist I worked for used to say less than 4 for their potassium. So they would have a supplement almost all patients who had arrhythmias after surgery like this. And they tend to need a lot of fluids still, colloid support if necessary. Occasionally they've needed things like plasma or things like that. The best thing to help improve a lot of this is to get food in them though. So especially for albumin and other things. So arrhythmias can start really anywhere up to 36 hours post-op. So if you're seeing anything abnormal during surgery or before surgery, definitely keep them on telemetry afterwards. This is just a few more notes of monitoring versus treating them. So in general, the reason we consider treating them is that they could suddenly die with these kind of arrhythmias when they're really back to back on top of each other. When do we consider treating? Really, if there's something obvious showing decreased cardiac output. So poor pulses, multiform VPCs, RNT, or a VTAC greater than 180. These technically, when they're slower than that, these technically aren't VTAC, they're not ventricular tachyarrhythmias. It's actually called an accelerated idioventricular rhythm, kind of similar to spleens. So if it's slow, if the heart rate's 100 to 120, even if it's rows of VPCs, you don't usually need to do anything about it, just monitor. So for treating the arrhythmias, just like any other patient with VPCs or VTAC, you want to make sure that you cross all the metabolic reasons off your list before switching to just meds for them. So you want to make sure they're adequately hydrated, they've got pain meds on board, their electrolytes are corrected. If you've done all those things and they're still having some arrhythmias that need to be treated, typically lidocaines are go-to. You can do a bolus of 2 mg per kg up to about 8 mg per kg, or until they start vomiting because it makes them feel pretty crummy. And then a CRI, lidocaine CRI at an antiarrhythmic dose is usually anywhere 40 to 80 mics per kg per minute. More like 20 is more like a pain response, but sometimes that's enough for patients with mild arrhythmias too. And then once they're able to take oral meds, or once you break the VTAC cycle, starting them on sotalol is sometimes a good idea too. Procainamide theoretically you can use too. So dogs that have had a previous gastropexy and present to you kind of like bloat. So take an x-ray, make sure that that's not actual bloat, make sure, because sometimes theoretically, at least the pexy site can break down and they can essentially bloat or GDV again. But if it's just distended like this, usually you can just treat them symptomatically. So this patient had presented, sorry, let me go back. This patient had presented bloated like this, but it had previously been pexied. So then we decompress the stomach, and here it is after we decompress. So it's in a normal position, comfortable, relaxed, and this dog did well. So sometimes you just treat them symptomatically for gastric inflammation, gastritis, basically. So some key points. Place 2 cephalic catheters, decompress the stomach as quickly as you can on presentation, get IV fluids and pain medications in, pick your pain medication of choice that's not Buprenex, so methadone, hydro, fentanyl bolus, whatever you want, usually a pure mu agonist is appropriate. Get your baseline, so some lactate, blood pressure, get through the history with the owner, know how long they've been this way, what's happened leading up to this. When you get into surgery, always do a gastropexy and thoroughly explore for foreign bodies. And then at any at-risk patients, it's always a good idea to do a prophylactic gastropexy, but they do have some risks with those too. So, and then I have a whole bunch of references if anybody's interested. Right. I think that's about it. I do have oops, I don't know what I did there. I do have a checklist of stuff for GDV if anybody's interested. It basically goes through kind of what to do when. Let me see if I can get this back up. There we go. I do have a checklist, so if anybody wants it, I can share it. We can post it. We can put it. I think it's in my P drive. So, yeah. Are there any questions? I guess.
Great. Thank you very much for doing this, Dr. Retallack. I appreciate it. Just before we go to any questions, I just want to let everybody know for attending the CE, if you could shoot me a quick email and just let me know that you were in attendance. Sometimes it's hard for us to figure out because there's just first names or no name at all. And shoot me that email so that we can make sure you're on the list to get the credit for the CE too. So with that said, does anybody have any questions for Dr. Retallack?
I had one quick question, Lauren.
Yeah.
Thank you. Have you seen any evidence for using sotalol in these patients after we get them on lidocaine and their arrhythmias are resolved? I feel like we've jumped more to this in recent years, and I haven't seen any real papers to support it, but it seems like a thing that we do more and more commonly.
No, I haven't seen any papers, but that's something I noticed I clinically started doing, especially throughout my residency, is I would see some, give them a couple lidocaine boluses, break the cycle, and then pretty much just start Sotalol,
Yeah.
12 hours post. And I feel like when I do that, I'm able to get them off of the lidocaine CRI faster and get them home better. My only problem with the lidocaine, it's nice from a pain standpoint, but it makes them feel so crummy. So like I've come in and I've looked at a post-op GDV and I'm like, oh my God, you look awful. You're just lying there. You're just gurging and nauseous. And then I stop the lidocaine. They're like, oh God, I feel better. Let's go. So I don't know. When I have them come back for their ECG recheck, I ask them to stop the Sotalol 24 hours before their appointment to check. And I usually monitor their blood pressure after starting it just to make sure that it stays okay and we don't take that, but I haven't seen any objective evidence on it.
Okay. All right, great. And that's really nice to know that you do that at recheck too. Thank you.
Yeah. Same thing with spleens too, if we have to do it.
Sure.
Start Sotalol or anything.
Cool.
Great. Any other questions before we end the presentation?
I
I
don't
have
think so.
one.
Oh, go ahead, Sammy.
Okay, so just in the ER standpoint, as far as 2 cephalic catheters, that's obviously always our goal. But if we can't get a second cephalic in, is there any point in putting in a back leg catheter?
Yeah.
Or is it better to have just do the one?
If you can get a saphenous into, like, I wouldn't delay getting into the OR trying to get a second catheter in. If you have one, just start with that. But a cephalic and a saphenous is better than just one cephalic if you can.
Okay, perfect. Thank you.
Yeah. Anything else?
I was just going to say too, for everybody, thank you for coming. If you have any feedback, please let me or Dr. Retallack know. Next month, Dr. Lunk is going to do a lecture on diabetes and DKA. I think it's March 15th at the lunch hour, but we'll let you guys know about that soon.
Also, if you guys want to hang out and talk about the Krebs cycle, I'm here for it.
I'll stay and talk to you.
Yeah.
Thanks, Lauren. We really appreciate it.
Yeah, no
Thank
problem.
you very much. Okay, I'll go ahead and end the presentation and thank you.